Welcome back to the Yellow webinar series. This morning, I have a great pleasure and privilege to introduce you Giulio Marchesini, who is full professor of metabolic disease and clinical dietetics at the University of Bologna, Italy. Giulio and I are, the friendship between Giulio and I goes back almost 40 years ago, which means that we are very young. But Giulio, there's no need to present Giulio. Giulio is an opinion leader worldwide known in terms of NAFLD or MAFLD, as I like to call it, and the metabolic distress involved in liver. Giulio was very kind to accept our invitation, and I leave the podium to Giulio, who is going to address the very exciting and active field of NAFLD and type 2 diabetes and ominous association. Giulio, you are the boss. Thank you.
Yes, thanks, Claudio. I try to share my screen, and please confirm that you can see what I am going to present.
Yes, maximize the screen and we are set.
Okay.
Perfect. Go ahead.
Well, we are talking about NAFLD and type 2 diabetes and the association which is shared by these two conditions. And first of all, I would like to thank the Yellow webinar and Claudio for inviting me. I am deeply involved in the area of sharing with my colleagues and with the community the importance of NAFLD, and those two pictures you see on the right of this presentation are taken from one of my last duties that were to build up a sort of patients' guidelines in order to increase the awareness of the population on this very, very diffuse disease, which does not receive as much attention. Really, diabetes, steatosis is quite common in the population. And when I was younger, or at times when we, Claudia and I met, we were used to say that fat in the liver was no worry, and nobody had to take care of. It was something linked to a larger diffusion of weight or a larger diffusion of adipose tissues throughout the body. And that was probably true in principle, but the ambiguity of NAFLD has been maintained through the years, despite the evidence that in a few patients, let's say in some 5 to 10% of patients, the presence of steatosis in the liver, which is, I repeat, very, very common in the population, may go on and proceed to necroinflammation, fibrosis, and finally advanced fibrosis, cirrhosis, and also hepatocellular carcinoma. So we need to spread the information to the all the physicians or all the healthcare net of the importance to look after these conditions, and the association of NAFLD and diabetes is particularly relevant in this context. I will briefly go through these 4 points of my presentation: epidemiology, natural history, from NAFLD to diabetes, obesity, and vice versa, and finally a few issues on treatment. Let's start with epidemiology. The global prevalence of NAFLD is really impressive because we are dealing with approximately some 25% of the adult population. There are large differences between countries or continents in the prevalence of NAFLD, and these differences are partly due to different methods to evaluate the presence of fat in the liver. It's very different if we measure fat in the liver by ultrasounds, if we make more precise determination of the amount of fat by the technique, which is magnetic resonance imaging, proton density fat fraction, and with an upper limit of 5%, or liver biopsy. Obviously, liver biopsy gives a representation of steatosis in patients who undergo liver biopsy. And which patient undergo liver biopsy? Those who have a reason for taking a liver biopsy. So probably the prevalence we find of steatosis in these patients is 100%, because if we make a liver biopsy, we had in our mind the idea that these patients might be. So if we look at the general population, the most common way to measure the presence of fat in the liver is definitely ultrasounds. And by ultrasounds, we have to consider that fat in the liver is only seen if it reaches approximately the proportion of 20 to 30% of droplets of fat inside the hepatocytes. So it's quite higher than the real intrahepatic triglyceride concentration we can measure by proton density fat fraction. If we look at another, oh, God, it doesn't move on. Oh, this is a representation of the prevalence of fat in the liver in different continents and in different studies, according also to the methods by which they are measured. And as you can see, there is, what is worrying is that in any countries, in any continents, there is definitely an increase in the prevalence of NAFLD across the years. Probably part of this increase might also be explained by the fact that we are much more interested in the measurement of fat in the liver, so there is a sort of detection bias. But nonetheless, if we look at precise determination of fat in the liver, as for example, this rather recent paper from China, where they systematically screened the presence of fat in a larger population, and they were really surprised by the rapid increase in the number of patients who are accumulating fat. This is probably explained quite easily by the totally different conditions of living in China that have been changing during the last 20 years dramatically or terrifically in a positive sense. That is, they eat well, they are getting fatter and fatter. And this is probably the problem. Which are the risk factors for NAFLD? And as you can see here, all the components of metabolic syndrome are definitely increased in patients with NAFLD. And if we look at the presence of these conditions in patients who undergo liver biopsy because of fat in the liver, which are probably the top and the most severe part of the population, of the NAFLD population, we see that, you see that obesity is present around in 80% of these guys, which are the guys who will later be involved in randomized controlled trials, and 55%, 54% have diabetes, 83% have hyperlipidemia or dyslipidemia, that is either an increase on triglycerides or a decrease in HDL cholesterol. 80%, nearly 80% are hypertensive, and 71% may be classified as a patient with metabolic syndrome according to the well-defined criteria. If we look at more precisely inside this population, we can see various things which are definitely important. The first is that most of the majority of these patients have cardiovascular disease. And NAFLD is independently associated with endothelial dysfunction, arterial stiffness, and also myocardial infarction. And this is probably the reason why we have to take care of these patients primarily for their cardiovascular involvement. If we look at another condition, obviously, this also means that we have to take care also therapeutically or with intensive screening of all these patients, because they are at very high risk of death for cardiovascular diseases. The second point is obesity. Obesity is linked not only to diabetes, to cardiovascular disease, but also to NAFLD and NASH. And why is obesity so common in NAFLD? Because obesity is the other face of the situation. That is, as long as fat accumulates in the body, it also accumulates inside the liver, and is a key contributor to lipotoxic damage and inflammation, and later on it contributes systematically to the amount of fibrosis inside the liver. And indeed, there are a lot of studies showing that the presence of obesity is also associated with a more rapid progression of fatty liver towards more severe stages of diseases. And obesity is extremely common in the population. Possibly you don't know that the number of patients with morbid obesity, that is of very, very obese patients in China, has recently overcome the number of very, very obese patients in the United States. We were used to figure out that the United States was a country where we had a lot of patients with morbid obesity. Yes, the United States have a lot of patients with morbid obesity, but morbid obesity is even more frequent in terms of total number. Obviously, there are 3 times as many in the population. So as a percent rate, the obesity in China is not as impressive as in the United States, but nonetheless, also in China, there is a great diffusion of obesity, as we have a lot of obesity in a few countries around the Mediterranean area, and most of all in Arab countries. You see, more than 30% of these of adults living in this area are obese. And also we have a very, very massive obesity in population living in the Philippines or in a few islands of Pacific islands. What is relevant, and I want to stress this immediately, is that if we look at what happens of the relationship between obesity and fatty liver, and if we look at the population who are educated to lose weight, or if they increase in weight, well, any increase or decrease in body weight carries out a change in the number of patients with obesity, with NAFLD. As you can see here, in a population where we had systematic screening of patients, if we have a resolution of NAFLD, the number of cases with developed diabetes are decreased, but as soon as we have an increase or a new generation of NAFLD, we have an increase in the number of patients, or we have a new incident cases with diabetes. and progression from mild to moderate to severe NAFLD carries out the largest increase in the presence of new cases of diabetes. The third issue, as I told, is diabetes. And diabetes, obesity, NAFLD, and insulin resistance are each independently associated with the risk of diabetes. And diabetes is another of the conditions which are very, very high in very, very highly increasing in the all over the world. This is an estimate of the presence of diabetes in the world. As you can see here, we have an enormous amount of subjects with diabetes. The total number in the world is estimated at present around 550 million people, but they are expected to increase by nearly 100 million in the next 10 years, and by another more 150 or 100 million in the additional 15 years. And all over the countries are facing this massive increase in diabetes. Obviously, in countries where we have just a very, very high rate of diabetes, the increase is probably less. But we are frightened by the possibility of having in the future millions of more people with diabetes in Africa or in Middle East or in other countries which are by no means able to cure this disease. The global and regional prevalence is possibly what I had just shown you, and this is what is present now. So we have these three pillars: diabetes, obesity, and NAFLD, which are all intimately connected with each other. And the natural history says that we may move from simple steatosis to NASH with severe fibrosis in some 10% of cases, but we have a few cases who will develop cirrhosis very, very slowly with time, and another group, we are so-called rapid progressors, which are the most severe cases. And in the middle, we have NASH with or without severe fibrosis, and all are expected to progress with years. The relationship between diabetes and advanced disease is something which has been a part of my research for years. And I will show you something which dates back to 30 years from now, which was the relationship or the percent of survival of patients with cirrhosis in the presence or in the absence of diabetes. You see, patients with diabetes had a very, very low or a lower survival rate in comparison to patients with cirrhosis without diabetes. What was surprising at the time, that is 30 years ago, was that the diabetes was not associated with the short-term survival, but it was indeed associated with long-term survival. What does it mean? It means that diabetes probably is something which may, in some way, account for progression of liver disease, and in the long run, it comes out to have a terrific impact on survival, together with most other variables, which definitely may have also impact in the short time. For example, ascites, encephalopathy, Child-Pugh score, or the presence of varices. So we have been accustomed for a long time to take care of diabetes in our patients, and we looked at several other studies which at the same time were coming out. And this is something very interesting, because is a study carried out in Italy, in a different area where I live, where they studied prospectively a cohort of patients with diabetes and looked at which were the reasons for the mortality in this population. Obviously, there was in this population a higher mortality in comparison to standard or to the general population for diabetes, and there was also a higher risk of dying of cardiovascular disease, which has long been associated with the presence of diabetes. What was surprising at that days was that also gastrointestinal diseases, and particularly chronic liver disease and cirrhosis, were identified as a reason for an increased standardized mortality rate in patients with diabetes. And look at it, the rate of disease or the risk of disease for cirrhosis in this population was even higher than the risk associated with cardiovascular disease, which does not mean that patients with diabetes die all of cirrhosis or die of cirrhosis more than of cardiovascular disease. It simply means that compared to the general population, where, by the way, the risk of dying of cardiovascular disease is very high, as it is very high in diabetes, the risk of dying of cirrhosis in this population was even higher than the relative risk of dying of cardiovascular disease. And this group of Verona went on along the years, and they finally identified that the higher risk of dying with cirrhosis was the presence of what at that time was called a non-virus, non-alcohol related chronic liver disease. But non-virus, non-alcohol related chronic liver disease is definitely the NAFLD. The NAFLD progressed to cirrhosis, is non-alcoholic steatohepatitis, NASH cirrhosis. And the finding that obesity at that time was also identified as an independent risk factor for clinical decompensation in patients with cirrhosis. This is a study coming from an Italian co-worker of mine who has now moved to Switzerland. And as you can see here, the presence of overweight or obesity is associated with a higher risk of clinical decompensation in patients with obesity, in patients with cirrhosis, and the overall risk of having a bad outcome was definitely higher and progressively higher with progressive BMI. The clinical, a lot of studies have, following this evidence, have seen that patients with NAFLD and NASH have a bad outcome in terms of cardiovascular outcome, in terms of cancer also. And this is something which have to take care of additionally. And if we look at cancer, for sure, the possibility of dying of cancer in this population is very, very high. And we have to consider this with very careful attention in our patients. Nonetheless, the presence of diabetes, if we put together all the clinical predictors of NASH or progression of NASH in patients with NAFLD, we find that diabetes is something which is always present. And I was saying before that the presence of diabetes is also important. And if we look at the possibility of progression from NAFLD to NASH cirrhosis and to NASH hepatocellular carcinoma, with the accumulation of these factors, which were diabetes, hypertension, dyslipidemia, and obesity, you see that the risk of dying of developing an hepatocellular cancer is progressively increased. And very old studies, the pivotal study carried out in the United States at the end of the last century, showed that the presence of BMI is definitely associated with a very, very high risk of dying of cancer, of hepatocellular cancer, both in men and in women, together with a sort of other association with all cancer. What is important is that these studies have been extremely validated. We have a massive literature on the risk of dying of hepatocellular carcinoma in patients with non-alcoholic fatty liver disease. And what is important is patients with NAFLD-related hepatocellular carcinoma are usually older, have a higher BMI, and are more likely to have also metabolic comorbidities than patients with hepatocellular carcinoma due to other causes, which, by the way, will also impact with their ability to be transplanted. Another issue, from NAFLD to diabetes. But it's the problem is that it's very difficult to disentangle NAFLD and diabetes because they are so intimately connected. Nonetheless, if we look at the association of NASH with incident type 2 diabetes, we see that a lot of studies have found that NAFLD is independently associated with incident diabetes. That means that having NAFLD carries a higher risk of having diabetes, as well as, and this is what I've shown before, having diabetes carries a very high risk of having NAFLD. Diabetes is also associated with liver disease progression. In these studies, which was carried out with the evaluation of transient elastography, they found that type 2 diabetes was associated with a double, 2 times increased risk of having a progression in liver disease. And whatever together with a sort of other conditions that, by the way, are always the same associated with the presence of NAFLD. But type 2 diabetes, and you can see also that also glucose above 100 milligram per dl, that is not only diabetes, but also pre-diabetes, is associated with a higher risk of progressive liver disease. A lot of Italian studies have also shown that also the presence of NAFLD is associated with a higher risk of diabetes complications after multiple adjustment, and also with the presence of chronic kidney disease and proliferative laser-treated retinopathy, independent of confounding factors. So NAFLD becomes some sort of accelerator of all the diseases which may occur in patients with diabetes. If we, to explain all this, we have to take care of how does diabetes progress in the population. The incidence of diabetes in the population or in an individual moves through different stages. We have an area of pre-diabetes during which we have a progressive increase in beta cell function, which try to compensate for a mild increase in fasting plasma glucose. Later on, the ability of the beta cell to produce insulin declines, and diabetes appears definitely because the amount of insulin is no longer able to face or to counteract the increasing glucose. During this phase, we have definitely the development of microvascular complications, whereas the development of macrovascular complications probably starts earlier. Well, if the liver fat is the hallmark of NAFLD, but we have to consider that fat does not only accumulate in the liver. Fat also accumulates inside the pancreas. And we have a definite association between fatty liver and fatty pancreas. And in patients with normal or pre-diabetes or diabetes, there is definitely a different risk of having NAFLD in the because the same conditions which causes the accumulation of fat in the liver also causes accumulation of fat in the pancreas. In the pancreas, the fat goes around all over the pancreas, inside the exocrine pancreas, but also inside the endocrine cells. And this disrupts the ability of these cells to produce insulin and decreases the beta cell index, which is a marker or an estimate of the ability of the beta cell to produce insulin. This is the difference in beta cell between control and NASH. And this ability to produce insulin is not so mild, so much decreased by the presence of steatosis, but is massively impaired in the presence of fibrosis. So the higher the progression of liver cell damage, the higher the progression also of the pancreas, of the pancreatic function, which leads to the diabetes. We may skip this because they do not say much more than I have already presented. A few issues on treatment should be definitely provided, because at the very end we have to consider how to cure our patient with diabetes and NAFLD, or with NAFLD independent of diabetes. What we know now is definitely that the only curative or the only possibility to treat patients with NAFLD with success is to have them lose weight. And this is a very important Cuban study. 293 patients with histologically proven NAF encouraged to adopt recommended lifestyle changes to reduce their body weight. 1/3 of them had normal glucose, 1/3 had pre-diabetes, and 1/3 had diabetes. And as you can see here, at the end of 1 year, we have NASH resolution in over 1/4 of cases. We have a decline in the necroinflammation activity in approximately half of the patients. And we have a reduction or a regression of fibrosis in 20% of cases, and a portal inflammation, which is deeply reduced. The evidence that weight loss is mandatory to have an improvement in NAFLD comes also from studies carried out by bariatric surgery, where it is very well known that bariatric surgery gives a resolution of NASH according to the amount of weight loss, and the weight loss higher than 10% of 10 kilograms of body weight, which is nearly 10%, by the way, because most of these patients weigh around 100 kilograms, leads to a resolution of NASH in 90% of cases. And we also have an evolution of fibrosis after bariatric surgery. You see the number of cases with or without, or with fibrosis score F0 goes up to 60%. And we also have an evolution of NASH, which is fairly less aggressive following the weight loss. But weight loss is also mandatory if we want to achieve diabetes remission. And in the same group, or in the bariatric surgery, is also able to lead to a substantial remission in type 2 diabetes. This is a part of the very, very important Swedish study where they measured the possibility to induce remission of diabetes with bariatric surgery. And as you can see here, over 75% of patients with massive obesity and diabetes who are submitted to bariatric surgery gain a complete remission of their diabetes, which is maintained also during the time without medications. Is it possible to achieve the same data with simply education or with a weight loss behavioral procedure? Probably not, because for sure bariatric surgery is very effective to reduce body weight. But what we know is that if we are succeeded, or we can reduce body weight in our population, we are expected to see a substantial improvement in body fat. And together with improvement of body fat, we also have an improvement in intrahepatic fat. For sure, this may be achieved by a Mediterranean diet, a low-carb diet, more effective than with other strategies or with other dietary procedures. And we have several studies looking at the effectiveness of dietary interventions. And for example, in this study, the dietary intervention was carried out according to the restricted American Heart Association diet, the NASH diet, or with other diets similar to the fatty liver index study or the Mediterranean diet. And as you can see, all diets tend to reduce liver fat, tend to have a sort of improvement of liver stiffness, and they definitely are effective on fatty liver index, reduce the amount of fat in the liver, and they are extremely effective also in reducing the liver enzymes. Other procedures have also been tested. For example, the possibility to treat patients with a very, very low calorie diet. This is something which has been carried out in Great Britain by a very solid group, and they did an intervention, a massive intervention with a very, very low calorie diet for 2 to 8 weeks, for 3 to 5 months. And later they introduced stepped food reintroduction and structured support for long-term weight loss maintenance. And what comes out is that In the intervention group, 24% of patients lose more than 15 kilograms of weight, and 46% of individuals who are submitted to this diet resolve completely their diabetes after 12 months. And this remission is definitely expression of the amount of weight loss they can achieve. What is relevant is that in all cases, liver fat is dramatically reduced. Pancreatic fat is massively reduced. Glucose stimulated acute insulin secretion returns on only in responders. What does it mean? It means that if this fat in the pancreas stays too long, there is no possibility to restore an effective pancreatic secretion, so diabetes is irreversibly maintained. Is it possible to be more aggressive? But probably yes, and we can educate our patient with different activities. For example, also we may try to educate patients or have to make some sort of behavioral intervention by using e-coaching now, and the percentage of patients who achieve an effective weight loss in patients with diabetes and obesity, as you can see here, followed by general physicians, general practitioners, is probably not as high as the one we have seen before, but nonetheless, we have a number of patients who may lose some 5% of, or also 10% of their body weight. And this is what we have tested in the last 10 years, using a specifically developed program to educate our patients also by the web in order to reduce the cost of the intervention. You can see here the amount of weight loss is reasonable and is probably similar to the amount of weight loss which may be obtained by simply educating patient with behavioral group intervention. And we have now finished our revision of our patients, and we have looked at what happens to populations which are educated by web or by groups. We have a very large population of NAFLD, largely with diabetes or pre-diabetes. And as you can see here, in a 5 years follow-up, we have a substantial maintenance of the amount of weight loss in those who continue follow-up, which are, by the way, a minority of the total group. And we have a substantial weight loss, which reaches also 15% in a few patients. And these patients definitely do not develop newly detected diabetes. We have definitely able to reduce the number of patients who develop diabetes to a number which is probably much more than expected and on the basis of the literature. And if we look at what happens of their liver disease tested by surrogate biomarkers, you can see here the changes. We have a dramatic change in fatty liver index, and we have some changes also in fibrosis score, and fatty liver index is declined, and the number of patients who are no longer identified as carriers of steatosis increases dramatically. Similarly, if we look at the number of patients who do not progress to advanced fibrosis, we have a higher number who is maintained out of their severe liver disease. What about the patient with more advanced disease? Well, if we are successful in obtaining weight loss in our population of patients with cirrhosis, as it was done in a very specific population, we can get some 10% decrease of, or 5% decrease of their body weight in around 50% of the patients. And these patients definitely tend to reduce also their wedged hepatic pressure. That is, in some way, we are protecting them from developing advanced liver disease and possibly gastrointestinal hemorrhage. This is my last, one of my last pictures. We are now testing also the possibility that the beneficial impact on weight loss is something which adds up and is complementary to an improvement in glucose control, in liver disease progression, in NAFLD progression, achieved simply by testing or by a better metabolic control. And we have now drugs which are very, very effective on weight loss. For example, the dual agonist GLP-1, GIP receptor agonist, and we have patients who lose some 15% or more of their body weight, and this has opened the possibility to have a successful treatment of NAFLD. In summary, what I would like to remind or trying to summarize is that NAFLD develops probably very early in our population. We have data regarding genes and epigenetic influences on the possibility to develop NAFLD. Progressive during the life, in most cases, we have some sort of increasing body weight from early adulthood to late adulthood at senescence. But this modest increase in body weight does not intercept disease. In a few cases, it starts earlier, it's larger. It may intercept the area of diabetes or pre-diabetes, or the area of obesity, and cause in some way some overweight, which ends up with diabetes and also NAFLD-NASH. And in other cases, it may be higher, and it came out to intercept also the area of liver disease, causing a real liver disease, which is accelerated by diabetes. And in a few cases, it may be as fast and as high that liver disease becomes primary, and it causes liver-related death. This is something which we have to consider in order to screen our patients, and this is what will be our future job, to find a way to have better screening procedure for our next patients. And I thank you for your attention.
Thank you very much, Giulio. This was an excellent presentation.